Okay, so which one first? Might be we just give the
We
last
only,
one, right?
yeah,
The L.
L, yeah, we only have L, I believe.
Yeah.
We
LA.
only, yeah, we only have L, the patient L, yes. For now.
Okay. Actually, so mostly she stayed home. So she was sick in 2020 during the COVID area. So she actually complains about stomach pain. Yeah. And she had a lot of investigations, several endoscopy, colonoscopy, ultrasound, CT scan. Yeah, from 2020 up to the last one was 2024 January. So basically the endoscopy, we feel that she had a lot of inflammation in the stomach area and duodenum, and maybe also colitis. Yeah. So her symptoms mostly gastric pain and burping a lot, and nausea. Yeah. A lot of muscle joint pain. She lost a lot of weight. She lost her appetite. I saw her maybe a month ago. She couldn't even like eat solid food. So just only
very serious.
Food.
Right.
Yeah, that's right.
Okay.
In January 2024, the CT scan found that they suspect that she might have like stomach cancer. But the capsule endoscope did not find the cancer.
Right.
And no further test because she refused. She upset. She doesn't want to have another endoscopy or colonoscopy. Yeah, sometimes she has constipations. Yeah.
Okay.
Yeah,
okay.
That's right.
Yeah.
So actually, the gastroenterologist her on a lot of like proton pump inhibitor, yeah, and
yeah.
even like Salofac, yeah, for colitis, and but she improved with that. When I visited her, she felt very nauseous. So I just barely asked her to stop the proton pump inhibitor and just give the Motilum or Peridone, and I gave her the Digest Basic with contents of enzyme and probiotic. And for a lot of gas, I give this flat pill, yeah, which is Simeticone. And she feels better with my treatments, and she is now no more nauseous, but the pain in her stomach still quite strong.
Okay. Okay. Yeah, and what is her diet like?
I'm sorry?
What is her diet like now? What diet is she on? Can she have a solid now or
no, still liquid.
Still liquid, right?
Yeah.
Okay. Yeah, and what sort of liquid? Is it like plant-based type
yeah, sometimes like protein drink, like the liquid one that contains of, like intrazole, something like that. Yeah.
Yeah.
And actually, I proposed her to have like CTC test, right? But she refused the blood test at this moment, so we're not able yet to get the blood.
Right. Yeah, I think that would be good, right? With I think we have a on-call trail, the RGCC on-call trail for the stomach, for colon anyway. Yeah. That would be very appropriate, and maybe some food allergy tests, looking at the plants that she blend, and the type of protein might be useful. But Peter, are you ready to share screen on this report we have, the CDSA3 plus?
Yeah. Look, thanks, Edward. Bear with me. We'll share the screen.
Okay.
Okay. So this is the patient's results. The stool CDSA level 3 plus results. So
we need to change the doctor name to Dr. Isabella from Jakarta later.
Okay. Yes.
Yeah.
I wasn't sort of informed. Yeah, we'll do that. That's not a problem. Okay. So
but Tommy actually has that, right, Tommy?
Yeah, I already sent the editor report to the group.
Okay. Right. Anyway.
Yes. Okay. So from what you've sort of mentioned to me, I think we can practically skip the macroscopic and microscopic descriptions of the stool, because they're somewhat unremarkable, other than indicating that for the food remnants and the vegetable fibers, there's some level of incomplete digestion, which obviously is limited information, etc. But we'll link it up a bit further into the report. Okay, so looking at the next group of markers, we look at the digestive and absorption markers. For this patient, so where are we? I think it's page 2 of the report. So we're looking at the short chain fatty acids, the putrefactive ones, the pancreatic elastase, and the long chain fatty acids. So we see the putrefactive short chain fatty acids. We have a result that's mid range, or a bit higher. So that sort of suggested that there's incomplete protein digestion. There's something that's present, and that possibly digestive enzymes are a consideration here to ensure better digestion. The pancreatic elastase is a marker that's used to assess exocrine function. Now, as much as it's at 406, it's mid-range, or just a bit below mid-range. I think typically our cutoff value is about 800. So it too's a little bit suboptimal. I mean, it's present, etc. But again, it indicates that there is suboptimal proteolytic digestive enzymes present. So that's a consideration that needs to be looked at and improved for the patient.
I believe digestive enzyme has recently been prescribed by Dr. Isabella, right? But maybe not before when this report was, this sample was taken. Is that right, Dr. Isabella?
So I think according to the procedure, we have to stop the probiotic and whatever. So I think I asked her to stop 3 days, no probiotic, because I give digest basic, which contains enzyme and probiotic. So I asked her to stop first 3 days as she collected the sample.
Right. So there's no digestive enzyme as well. Okay, so carry on, Peter.
Okay. So yeah, I think that supplementation is probably going to benefit the patient. And now we come to the metabolic markers, and we see here that we have a couple of abnormal results. So the first one being the beta-glucuronidase, which is excessively high. So this is an issue, and usually to treat this, we would be looking at improving or increasing the patient's dietary fiber. So that's the main one. Second would be the supplementation of calcium D-glucarate. That's important in that it will stimulate the liver to better detoxification processes, etc. And then thirdly, we would probably look at also the pre and probiotic supplementations to again, improve the gut status. The other marker that's out of range is the butyrate. So of the 4 short chain fatty acids, the beneficial ones, the butyrate is quite low. So it too needs to be improved. Improving the dietary fiber intake, that will help increase butyrate, but then you may also wish to consider butyric acid supplementation as well through the diet. The others are pretty much normal and within normal limits. So yeah, and this here's the comment in regards to the use of the calcium D-glucarate.
So calcium D-glucarate as well as butyrate.
Butyric acid,
butyric acid.
And where you can improve the dietary fiber intake as well, that would assist. So the inflammatory markers, we see calprotectins highly elevated. So calprotectin is a protein marker that's diagnostic of IBD. So it's quite clear that this patient is suffering from either Crohn's or ulcerative colitis,
giving rise to the pain that she's experiencing.
I would potentially, yes, without gastroscopy, colonoscopy, to confirm it, because obviously that's gold standard. A result of 248 is quite high, and it's very characteristic of those conditions.
Oh yeah, the preface of gastroenterologist already prescribed her Salofac, so that's usually for IBD. Yeah, but she stopped already maybe a few months ago. So they put her also on this medicine, but she, according to her, she did not feel also improvement, so she stopped.
I see.
So what would you suggest instead, Peter, for this?
Well, typically, we look at trying to improve the gut health by reducing the inflammatory processes. So the use of products like L-glutamine, slippery elm, omega-3 products, aloe.
What is aloe?
Aloe, A-L-O-E, there.
Oh, aloe vera.
Aloe vera. Yeah. They're all products that are anti-inflammatory. They're going to reduce the inflammation and assist in healing the gut. And then you could also look at products like zinc and other antioxidants to assist in the process. But typically the L-glutamine, slippery elm, the aloe vera, omega-3s, they're all anti-inflammatory and healing type products to bring down that inflammation.
Yeah, for certain medicine, it also quite difficult because her stomach will be very sensitive. It hurts a lot when she swallows some vitamin. Even like magnesium, it gives a lot of pain in her stomach because her stomach is very inflamed. Yeah, and there's also suspicions of the cancer. Even she had already several endoscopy done from 2020 up to 2023. The previous ones, or the endoscopy, no suspicion of cancer, but the last one, not endoscopy, but it's a CT scan, suspicious. Yeah, they suspect that it might.
And that's, I guess that's the progression of the condition. That's obviously led to the exacerbation and the potential that some sort of malignancy is developed over a period of time. But I guess without a sensitive and specific test, it's or a biopsy, or like RGCC,
RGCC, onco trail colon. So try to talk to her about that, Dr. Isabella. All right, that this is a very early marker detection that will not be detected through the colonoscopy, right? And it's better that can you hear me? So tell her that if
might be to give her the Salofac, like for IBD, and possible that the dose might be not enough to control inflammation. Can you hear me?
Yes. Sorry. Say the first part again.
Yeah, I think that's because in the past, the gastroenterologist prescribed her Salofac twice a day, 500, might be not enough to control her inflammation, so she did not feel improvement. So I think I can increase the dose, because sometimes you can give like 4 times a day 500 or twice a day 1000 for the Salofac, and L-glutamine, I think there's a supplement like this, right? That we can get it from Dr. Sarah, maybe. And aloe vera, so maybe I'm going to ask her to just maybe use the aloe vera, the original, the plants, and then to swallow it. Omega-3 is quite big, maybe. Is it okay, omega-3 from virgin coconut oil, so the liquid one, so she can swallow it, because for a big capsule, I think that she find it difficult to swallow it.
Well, coconut oil don't have omega-3, Dr. Isabella. So there can be other oil. That can be other oil. We can send you some details of that omega-3 oil. That is possible for her to use. Yes. Plant-based oil.
Okay. All right, so maybe Peter want to carry on.
I will reshare my screen.
Yes. And Peter, you mentioned just now the calcium glutarate and also the calcium buretates, right? So if we take the calcium buretates, is it necessary also to have the calcium glutarate? You can get the calcium through there, or is it the glutarate that is important as well as
the product calcium D-glucarate
D-glucarate,
is highly specific for its effects on the liver and to assist in bringing down this elevated beta-glucuronidase. The butyric acid, the butyrate, does not necessarily need to be a calcium derivative type product.
Right. So that will be addressing the butyric acid issue.
Some of the other things, some of the other processes that are happening are also not allowing for adequate short chain fatty acid production. So we have to work on several other things to improve the beneficial bacteria levels, which are the producers, and some of the commensals, which are the producers of the short chain fatty acids.
Right.
Okay, so the other inflammatory markers we see here, the secretory immunoglobulin A of 592. So it's a little bit low. It's low normal, so to speak. So it's definitely suboptimal, and that can obviously lead to easier infections being transmitted, etc., across the gut. The protective barrier is at the moment minimal there for the patient. So looking at improving that over time as well. There is no issue with gluten sensitivity from the transglutaminase result. It's quite low.
So there's a recommendation of IgG, IgA food test there, right? That I saw.
The patient, I think the practitioner mentioned that the patients had these tests done historically. I think it,
Is that right, Dr. Isabella? She already had the IgG, IgA food intolerance test done.
No, that might be the last. I might ask her to do this. Yeah.
Right.
So the food intolerance test, right? IgG food intolerance test, right?
Yeah. I think the 240 would be the IgG would be most comprehensive. IgG, IgA, 240.
Yeah. The other, I mean, it is possible because of this high inflammatory condition that's present, that hyperpermeability is highly likely. Leaky gut.
Yes.
Leaky gut hyperpermeability is most likely because of the level of the inflammatory process. So there may be other delayed symptoms, etc., that the patient may be experiencing, or unrelated symptoms that may come from larger than normal food particles getting across the gut and being recognized as foreign by the body, which then generates an immune response against those food particles, which can come in the form of headaches, joint pains, redness, swelling, etc., that are somewhat unrelated to the gut, but the immunological process in the body generates these conditions. So identifying through an IgA food sensitivity test, you can identify where there are excesses of these particular antibodies present, and then particularly look at removing those food products from the diet for a period of time for the immune response to settle down, for the inflammation to settle down, and then potentially at a later date, 3 to 6 months later, slowly start to introduce those foods again.
Yes, and also you can run the zonulin or the gut permeability or leaky gut test as well to confirm.
If you're wanting to assess more frequently or assess the condition of the leaky gut, then you could look at 2 other products that we have, a fecal zonulin test, or the urinary intestinal permeability test, which is looks at the recovery of lactulose, mannitol, after a dose of those 2 sugars has been taken. Okay, so we move on. No indication of Helicobacter from these results. The tumor marker, it's a 2.8. So it's
something.
It's not elevated, but it's something. So I think, more knowing the history and the symptoms of what you've mentioned, I think it may warrant investigation because of these constant pains, etc.
Yeah.
So
like an IGCC OncoTrail colon.
Yeah, the E2 PK will be elevated or not in the gastric cancer?
Often it is. And it's a sensitive marker. So the fact that in this instance in the stool it is not elevated, but it is at the upper end of normal, would suggest that along with the other symptoms that you've mentioned, it may be something to look at, just to include or exclude it from the diagnosis.
Yeah, it is not as early detection as the IGCC OncoTrail test, isn't it? This marker, Peter.
Yeah. Look, the fact that it's present.
I mean, it is a tumor
it's
marker.
Not elevated.
Right?
It suggests that possibly there's something there. But there could at the same time also be some degree of interference from the inflammatory process that is present in the gut at the moment. We have to be transparent about that. There because there's a high-ish inflammatory IBD situation occurring, that there could be some interference or cross-reactivity due to that inflammatory process that is making this marker at the level it is. Right.
So no need to be too alarmed at this stage.
Yes and no. Yes and no. It's a individual decision that would need to be made. If you're suspecting that there is a malignancy there, then you should look at the RGCC test. The alternative is to potentially order this marker on its own in several months' time and see what the result suggests. If it continues to climb, then something is wrong. And obviously, let's say you also included in the next set of tests a calprotectin result, a beta-glucuronidase result, and an M2PK result on the next stool test that you did in a couple of months. You've begun treatment on the inflammatory process, so we would want to see, I guess, reduction in the beta-glucuronidase, reduction in the calprotectin. If there is no malignancy, then the M2PK result will also drop. However, if there is a malignancy, that number of 2.8 will rise. So it will, again, give more support to the fact that there is a malignancy present that needs to be further investigated.
Okay. Yeah. I have also M2PK test in Jakarta. So, but we have to also check the two bone markers because I have several patients with M2PK high, and then I sent for colonoscopy, turned out to be normal, the CA level normal. So I think that we have to do both. And the other patient that I sent also CDSA test, Mr. NDH. With the test here, also the M2PK normal, but a couple days after he sent stool to me, he had emergency and had to go to the hospital, and M2PK high. But the results that we have here normal. So maybe M2PK also doesn't always mean cancer, but it means might be inflammations, yeah. Because
correct.
within
Yes.
few days,
Yes.
yeah,
This is true. And as I said earlier, that we need to correlate the result to the other symptomatologies that are present and the clinical history. So for this patient, it may be that the 2.8 result is a consequence of the high inflammatory process that's in the gut at the moment. So, but if you do have those suspicions of a malignancy, then you might want to look at the other test, the RGCC test.
Yeah.
All right.
Okay.
So we now move on to the microbial aspects of the stool test. So the first group are the beneficial bacteria. Well, generally speaking, there are some low ish organisms. This is pretty much a typical example of what we see. So there will always be some deficiencies in the different strains. So that's not that unusual. There are no pathogenic bacteria detected in this sample. But what we see is that there are overgrowths in numerous opportunistic commensal type bacteria. Now, the relevance here is that they may be, forming part of the dysbiotic and inflammatory process that's currently present. So ideally, these need to be dealt with. You may not need to do it prescriptively. They can probably be dealt with using natural antimicrobial type products.
Do we have a report on sensitivities on this, Peter?
We do, and it's on the next page.
Yes.
or the page after the next page. So
right.
Yeah, we'll come back to how these organisms are to be treated shortly. And then the yeasts, there's a small growth of Candida, no parasites detected from this profile. Now, in terms of the overgrowth organisms that were detected, the following are the antimicrobial sensitivities. This first group here are the prescriptive antibiotics that one could consider using.
But at the same time, they would knock off the beneficial.
The beneficial, bacteria. Yes, yeah. But yeah, that they will. Yeah, all antimicrobials will have that effect.
But let's go with the natural one.
The antibiotics are somewhat harsher, obviously, and indiscriminate. So we also provide antimicrobial sensitivities for these organisms using natural supplements, inhibitors, etc. So you would look at the ones that show the greatest sensitivity. Yeah.
Maybe a combination, right? Looking
yes,
like berberine, caprylic acid combination might be. Yeah.
The most useful.
So for this case, we decided not to give antibiotics, but we give inhibitors, natural one.
Yeah, under the current status, where the patient is not doing that well, it may be better to start with the natural inhibitors rather than go the prescriptives at this point in time.
Okay, so
it'll be less harsher on the gut environment.
Okay, so for example, we choose which one? Berberine?
Yeah, just looking at the results, you probably look at berberine, caprylic acid. Yeah, they'd probably be the two best at this point in time.
A little bit of garlic.
Oh, look, yeah, the garlic would be a third option. Yeah.
Yeah, because they have they have different sensitivity strength on different organism, right?
Yeah. So
and what about the doses? How we give? We do combination, or we just give berberine first, and how many times a day? What the milligrams? How to get it?
Well, if you need to get it, we can send it to you, right? And in terms of the dosage, we can also provide that to you later. In terms of combination, I would suggest on different dose and at different time, because they can have a synergistic effect, as you can see, right? So maybe one in the morning, one in the afternoon, sort of thing. But we can send out a proposal to you.
Okay. What about the candida? Is this only positive one? Is it okay to have small amount of the candida? Because candida also can be just okay to be there, right? It's not excessively, it's just only positive one. So should we also concern about the candida here?
Yeah, I'm not hugely concerned about the candida. A growth of a small growth present is not unnatural or not normal. So I probably wouldn't be too concerned about that. It's the bacteria that are at these ones here that are at 4+. As an overgrowth. There's just too many of them there as an overgrowth, so they're part of the problem.
Okay.
So
I think for the candida, brain also works a bit inhibition.
Sorry, you're asking for inhibition of candida, is it?
Yeah, I think that's because we're going to give the berberine. It also inhibition 60% for candida, so maybe that also can help.
Yeah. So on the next page after the bacterial inhibitors, we have the fungal or yeast inhibitors, and matching up what's the best out of both. Yeah, you could use the same products like berberine,
garlic.
Garlic or oregano. To get the best results. But you'd be, I guess, focusing more on inhibiting the bacterial levels rather than the yeast levels at 1+.
Like oregano, we have the oil base, that might be more preferred by her, for example.
Yeah.
Right.
Yeah. Okay, so that's the rest is just comments, etc., about the different organisms. So probably don't need to go into all of that. But yeah, so to sort of summarize, I guess, we need to address the microbial overgrowth. We need to reduce the beta-glucuronidase, and we need to definitely reduce the inflammatory process that's occurring. They're the key aspects of improving this patient's gut health.
Okay.
So any other question, Dr. Isabella?
I think that maybe can we go to the last page, the 4R, because this is just the for it's not for individual, it's for everyone, right? Like this, that we can choose one.
Yes, the 4R protocol is typically what integrative medicine practitioners use in treating the a destabilized gut environment. So you follow that process sequentially. You have to remove the offending organisms first, and can be done by, depending on what the organisms are, by different types of products. But obviously the effective products that are on the preceding pages of the report, they're the ones that you would use. Then you look at replenishing. So we look at the digestive enzymes, etc., to assist in supporting digestion. Reinoculating, well, we're then going to improve the prebiotics and the probiotic levels, and thereafter repair and rebalancing the overall environment that's there.
Okay.
So would you do it in a sequential basis, Peter, or at once?
Oh no, you can't do it all at once. It has to be done in that time frame.
So how long for each before you get to the next one? Would you suggest? Or we do a retest after the remove?
Oh look, it could take it could take a while. But you know, I also see the importance of and a sense of urgency, say, for this patient, etc., to try and get better improvement. But I would think the overall process might take a couple of months.
So you
between two or 3 months to get through the whole process. Yeah, it may take that long. Yeah, 6 to 8 weeks at the earliest. Up to 12 weeks.
So can we do the remove and replace at the same time? I mean, I can see the logic of not doing inoculate, right? So we remove, because the remove might knock off some of those guys. But even then, the prebiotic, I don't see any problem with the to combine it with remove and replace, right?
Yeah. Look, it might, you probably could do remove replace concurrently.
And maybe even the prebiotics on inoculate, because that is not sensitive to the.
No. Look, I think the re-inoculation part should be done after the first two.
Okay.
Yeah.
So we can do like a month with the first part, and then think about.
Yeah, you could. Yeah, like I said, it could take between 6 to 8 through to 12 weeks, depending on how it's done. If there is this sense of urgency with this patient, then yeah, you try and get it done, you know, in the 6 to 8 week period.
You mean overall? So that means for the remove and
And that way you can reassess at an early time period rather than waiting a long period of time. You intervene and reassess your position earlier.
Right. So 4 weeks for the first two concurrently, and then and another 4 weeks or so. Can we combine re-inoculate and repair concurrently as well? What do you think?
Sorry,
Peter?
which one? Which ones?
Re-inoculate and repair, rebalance can be combined. These two.
Yes. Yeah, you probably could. You probably could. Yeah.
That would speed up the process then.
Yeah.
Right.
Yeah.
So we do remove and replace for 4 to 6 weeks, and then another 6 weeks or so with re-inoculate and repair.
Sure.
Sounds like a plan, Dr. Isabella.
Okay, so I'd like to ask a question. For example, for the first one, remove, we give the berberine for this patient. How long are we going to give? 6 to 8 weeks, or just might be like, usually like antibiotics, we give like 7 to 14 days, for example, right?
Yeah.
Now for this,
so it would be a similar period. Because we're not trying to eradicate totally these organisms. We just want to bring their levels down.
Okay.
And obviously the natural inhibitors are not as harsh or as strong as the prescriptives.
Okay. So like berberine, usually how long you give?
Around 2 weeks.
2 weeks, yeah.
2 weeks. Okay. All right. So first we give, for example, berberine 2 weeks, and then we also add the replace together, right? So we give.
Yes.
Can we give the bedtime SCL here, because you can see that her endoscopy show a lot of inflammation and she has a lot of pain. Will be she has a lot of pain if I give the bedtime SCL or apple cider vinegar?
Well, you can try out and yeah, you can try out and see how well she tolerates it, right? As a condition improves, she might tolerate it.
So I can always
better.
try.
Yeah.
Increase.
Yes.
Okay. And for the replace digestive support, how long will we give to her?
For the replace, right? Wow, I mean,
yes, right.
yeah, I don't, I think this is always useful. That there's no need to, you know, to stop it per se. You know, as we age, you know, these are, you know, our digestion do get compromised. You know, you can maybe reduce the dose, but you know, always be considered on.
Okay.
Yeah, I think you just you know, have to progress with the replace portion of the protocol, see it through, including the inoculate and the repair and rebalance portions as well. That because that is more functional to assist digestion, break down those food particles, and prevent the food remnants being yeah, not being broken down and undigested and remain there. They become putrefactive, etc. So they cause other issues. So you may have to continue the enzymes for a period of time.
Okay. So after how many months should I repeat this test?
I would be looking at potentially maybe doing a some sort of test to determine the effectiveness of that supplementation. So you could potentially look at the pancreatic elastase on itself, by itself. You may want to look at locally amylase and lipase tests from your local lab to see what their levels are, and that would give you an early indication of the effectiveness of the replace protocol, that it has improved the digestive support.
Okay. Okay, so I think that's the end of this discussion today, right?
I beg your pardon. Sorry.
I think that's all right, because other patients might be, this one is quite complete to explain what we have to do. The other patients, Mr. MDH, I think I can, maybe if I have any question, I will just text, because he's not here. He is in the abroad, so I think he is seeing a gastroenterologist for colonoscopy. The other patient, the male one, yeah. So if I have any questions, I will just check with the well lab, and then if I
they can
need
pass it on to
other-
me, and we'll get back to you.
Yeah, that's right. So maybe I will get the summary of the conversation today, so our discussion today, so written one, so I can, actually I wrote already, but maybe if the well lab also can help me with the conclusion, that will be better. Thanks for that. Thank you for your times, and explaining to me, so it's clear for me now to better understand this test. Okay. Okay. Good morning. Shall we leave now?
Okay. Thanks again.
Okay,
And if you need any other assistance, don't hesitate. Contact Well Lab in the first instance, and then myself in the second instance.
All right. Thank you so much.
All righty.
Bye.
Thanks again.
Bye.
Leave you to it. Bye.
Good morning.